As a famous quote says, sometimes big problems are solved with small and creative solutions. In line with this belief, let's witness some interesting and challenging cases where large problems are solved with 41 gauge solutions. The objective of this case series is to exemplify 4 indications of 41 gauge needles in macular surgery. The first case describes a patient with massive submacular hemorrhage secondary to PCV. This case is classically treated with pars plana vitrectomy followed by subretinal injection of tissue plasminogen activator using a 41 gauge needle. After completing vitrectomy, PFCL is injected, intraoperative OCT is used, 41 gauge needle is used to inject the tissue plasminogen activator into the subretinal space. This needle is connected to the viscous fluid injection port of the Constellation machine for a controlled injection. Peripheral retinotomy is made, through which multiple fluid-air exchanges are done to get rid of the subretinal blood to the extent possible. Retinotomy was lasered and gas tamponade was given. You can see after 1 month a successful outcome with complete resolution of subretinal hemorrhage with BCVA improvement from hand movements close to face preoperatively to 6/24 postoperatively. Coming to second indication of a persistent macular hole post primary vitrectomy and ILM peeling surgery, the hole did not close. For the second attempt, macular detachment induction technique was planned. In this technique, as you can see, the 41 gauge needle is used to inject balanced salt solution into the subretinal space, creating a localized detachment. The injection is done superior, temporal and inferior to the macular hole. We can see the BSS spreading into the subretinal space, ultimately leading to macular detachment. This technique creates retinal redundancy and reduces retinal stiffness, ultimately with the help of gas tamponade helping into the closure of macular hole. The postoperative OCT shows the closed macular hole, and in this patient, the best corrected visual acuity improved from 6/60 preoperatively to 6/36 postoperatively. Coming to the next indication, in this case, after an uneventful retinal detachment surgery, a large subfoveal PFO bubble was found. Surgery was planned to aspirate this bubble with the help of 41 gauge needle. With the intraoperative OCT guiding us, the bubble is entered at its edge and the PFO bubble is aspirated. You can see after aspiration of the bubble, a fold is formed because of redundant retina. As this fold was involving fovea, we decided to repair it, which forms the fourth indication of our case series, which is macular folds involving the fovea. In the same sitting, we further used the 41 gauge needle to inject balanced salt solution all around the foveal fold, creating a localized detachment as shown in the previous case. This way, we provide the folded retina a larger area to settle on, ultimately helping to resolve the foveal fold. We can see the BSS spreading into the subretinal space, reaching to the macula and resolving the fold. Fluid air exchange with SF6 gas tamponade was given. Postoperative OCT showed encouraging results and the foveal contour ultimately returned to normal after 1 month with 6/24 vision. In conclusion, the use of 41 gauge needles may not only be helpful in cases of large submacular hemorrhages, but may offer significant benefits in treating failed macular holes, retained submacular PFO, and symptomatic macular folds following vitreoretinal surgery. I hope this video will be helpful in understanding the effective and safe use of the tiny needle to solve the big problems. Thank you.